All right. Hello, everybody. Welcome. Thank you so much for joining us today at the first session of our DSH Diversion Academy. We're very excited that you're here with us today and that you have elected to participate in our diversion program. And I'm hearing a bit of echo, so I'm going to go through and see who I can mute. All right. And on that note, I'm going to take us to the next slide. So here are all of the controls that you guys will have to utilize while you're in these sessions with us. So I'll run over these really quick. All of this should be on the far right-hand side of your screen. At the very top, you should see a blue participants icon and a chat icon. If those are selected, then the windows underneath will show you all of the different participants. When the participant icon is open like this, you can go through the attendee list to find your name. And next to your name, there will be a camera icon and a microphone icon. Those are what you use to turn your camera on and off, and we would sure love it if the majority of you could have your cameras on, if at all possible today, so we can see everybody's faces. That would be awesome. And then the mute and unmute button. So we do ask that you remain on mute when you are not speaking, just to limit the background noise in the recording, and I will do my best to monitor and go through as we're doing our presentations and mute anybody who maybe isn't on mute and just doesn't realize it, because that does happen. Further down on the right-hand side of your screen, or towards the bottom of that participant block, you will see all of these other little buttons here. And so what these are for are to communicate with us, the training panel. So the hand icon is to raise your hand when you have a question or a comment. And we will be pausing to take questions and comments throughout this presentation. So please go ahead and raise your hand. And if you have something that you need to say or a comment that you'd like to make, and we will call on you. The check button and the X button, those are typically if somebody in a training panel asks you a question that they want feedback on, and the check would be a yes and the X would be a no. The two icon figures here, you can use to tell us to either slow down our presentation if we're going a little too fast, or to speed it up if we're going a little bit too slow. There are also emoji icons if you just want to let us all know how you're feeling. And then this audio button, you can use this to change the source of your audio. So if you are using computer audio and need to switch to phone audio or vice versa, you can click on this and it'll guide you through changing your audio connection. The next thing that I want to point out, or next part of this setup that I want to point out, is the chat box. There is, if you again make sure this blue chat icon at the top is highlighted, you should have a chat box. If the arrow is pointed towards chat, that means it's closed. So you just click on it, the arrow will point down and it'll pop open your chat window and you can send us messages. I am going to request that you send messages to the entire panel and not just to the host. The host is me, and unfortunately, I'm not always going to be able to respond directly to technical requests while I am presenting, but somebody else on the team may be able to help you. So the best way to do that is to chat to the entire group. This is also another way for you to send in questions and comments to us. So we will be monitoring this chat box in order to track those questions and comments that may be coming in and make sure we address those. All right, a quick rundown of our agenda today. So we are going to start off the day with some team introductions, where we introduce you to the team on our side and you introduce all of yourselves to us. And then I'll be walking you through what I'm calling the nuts and bolts of our diversion program, which is really all of the different administrative aspects of this program, what you can expect to be doing with us as you move through the process of program planning to contract implementation, invoicing, and data collection, all of the kind of the main requirements that are part of this program. Once we get through that, we'll take a quick break, and then we will come back and have a conversation with Dr. Catherine Warburton, our medical director, who will be laying out for you the case for diversion in California. That will be followed by another short break. And then we will move into our breakout sessions, which will be led by the Council of State Governments Justice Center, where you will start to draft parts of your program plan with us here today. We will be taking questions throughout. We will pause repeatedly throughout the presentations to ask if there are any questions. And we will try to make sure that there is some time at the very end of the day as well for you all to ask any remaining questions you have. And of course, you can reach out to us at any time with other questions that may come up after today's presentations and training. You can just submit that to us, and there will be a email address that we show you in a little bit later on in the presentation where you can find that email address. All right, so now we're going to move into meeting the team. So I'll go ahead and start things off and then pass the baton along. My name is Ashley Brooks. I am a staff services manager too with the Department of State Hospitals, which doesn't mean a lot if you don't work for the state. So I typically introduce myself as a program manager for the DSH Diversion Project, and I work in our Forensic Services Division. As you continue down this project with us, you will see my name a lot, and we will probably be having a lot of conversations. So I'm very happy to be here to meet all of you, and I am going to turn this over to Dr. Sean Evans.
Hi, everyone. I hope you can hear me okay. My name is Dr. Sean Evans. I am a clinical forensic psychologist by training, and I am a senior psychologist supervisor and a DSH diversion program lead. I work with Ashley. I tend to handle a lot of the clinical related issues, and so will also be in contact with you, and I'm thrilled that you're all a part of this Diversion Academy. I'd also like to introduce Dr. Catherine Warburton. We'll hear from Dr. Warburton later today. She is the DSH medical director, and we were just thrilled to have her provide today's presentation. Also, I'd like to introduce Dr. Susan Velasquez. Dr. Velasquez is our chief psychologist in clinical operations, and she will be joining us throughout the Diversion Academy, and so you will get to know and meet her there. So I'm going to turn the introductions back over to Ashley, and she's going to continue introducing some of our clinical operations division.
Thanks, Sean. So the next set of folks that you see listed there under the clinical operations division are our data team, who you will get to know through the data collection process. They weren't able to join us today, but as Sean said, a lot of our team members will be joining us through various parts of our presentation throughout these sessions, so you'll be able to meet them and put some faces to some names. But to start off, we have Dr. Barbara McDermott, who is a professor at the UC Davis School of Medicine in the Division of Psychiatry and Law. She has been the research director here at Department of State Hospitals for the past 20 years, starting out at our Napa State Hospital location and now really overseeing that for the entire department. And she is heading up the team that's responsible for managing all of the data that we will be collecting through this project. And then on her team, we have Martez Mitzi, who's a research assistant based out of our DSH Napa location, who has been on Dr. McDermott's research team for the last 3.5 years. She works on a lot of different projects for the UC Davis research team in the Department of State Hospitals, and has been assigned to our diversion program for over a year now, and she does the bulk of the data processing for this project. And finally, we have Casey Murdoch, who is also a research assistant on our UC Davis team. She is based out of our Sacramento location and has been working with Dr. McDermott for the past 3.5 years. Like Martez, she works on a number of different projects, but she has been with us on diversion for the past 9 months and assists with the diversion data processing as well. So I'm looking forward to you all meeting them, and you will definitely be meeting them in the future when we get more in depth on the data piece of things. So now we're going to swap back over to the forensic services side of the house, and I'm going to see if my boss, Chris, would like to unmute herself and give a little introduction.
Hi, everyone. My name is Chris Edens. I'm the Deputy Director for the Forensic Services Division. And so Forensic Services Division, as you see on the slide, the diversion program is really overseen collectively by the Clinical Operations Division as well as the Forensic Services Division. I've worked in the department for over 20 years now. And just to share, under the umbrella of the Forensic Services Division, we not only oversee the diversion program, but we also oversee most of the other IST programs that live outside of the state hospitals. So jail-based competency treatment. We're now entering into the world of expanding community-based restoration programs. We also are going to be establishing more subacute capacity for ISTs. And then we also oversee the conditional release program along with some forensic evaluation programs. So very nice to see everybody, the list of individuals on the screen, and looking forward to the Academy. Thanks.
All right, thank you, Chris. Lisa, do you want to introduce yourself?
Yeah, good afternoon, everyone. I'm Lisa Pedlar, and I am an analyst working with Ashley and Chris in the diversion program. And my focus is primarily assisting with the administrative issues. So you'll be hearing my name, and I'll be talking to you as we get more in depth in once your contracts are executed, and we'll talk about finances and stuff like that.
Excellent, thank you, Lisa. And finally, we also on our team have a student assistant named Paula Nguyen, and she wasn't able to be here today, but Paula is a graduate student at UC Davis, and she helps us with a lot of special projects on as part of this program, and she's also responsible for tracking all of our county contacts and kind of streams of communication with the county. So another individual that you will be interacting with quite a bit as we launch into this project. Right, I'm going to do one quick screen just to see if there's anybody that I might need to mute before we move on. Okay. And now I'd like to turn the introduction baton over to our partners at the Council of State Governments Justice Center.
Great, thank you, Ashley. Am I coming through all right?
Yep.
Excellent. We're doing construction on my house, and we turned off power like 3 minutes before this. So I am thrilled that I'm here, connected, and talking to you all. My name is Hallie Fader-Cow. I'm a program director at the Council of State Governments Justice Center. I work in our behavioral health division, and I live in San Diego. And I am really excited to be working again with Department of State Hospitals on helping you all in standing up what we hope are going to be some really effective felony diversion programs to provide needed treatment for community members who otherwise would be going to state hospital. If you're not familiar with CSG, we're a national nonprofit. We work on criminal justice policy, and you may have encountered us before. We provide training and technical assistance through the U.S. Department of Justice for federal programs, federally funded programs in the Justice and Mental Health Collaboration Program, as well as the Second Chance Act. Here in California, we've been doing a lot of work with the state associations to stand up and promote the Stepping Up initiative. And over the last couple of years, we've been working with Department of State Hospitals and the Council on Criminal Justice and Behavioral Health to support counties that are implementing mental health diversion programs. I'm very proud to be introducing a team here at CSG and our jobs are really to work with your county teams to get you in a place where you have a strong program plan ready for submission to Department of State Hospitals. As I mentioned, we do a lot of training and technical assistance, and we really have a very team-based approach. So as my colleagues introduce themselves, you'll see that we have different areas of expertise, experience. You will have one of our team members joining you for breakouts throughout the academy. So we'll be there to help facilitate, answer questions, sort of be a support for your teams as you're making decisions about your diversion program. And if it turns out that there is a particular subject matter area that comes up, your coach will bring it back to the team and make sure that you are connected with the person who has the expertise who can best help you. So we're here to support you in your decision-making, moving through the planning guide. We're happy to do consultations on particular areas where you have questions, as well as help identify resources that might aid you in making good decisions. So with that, I will let my teammates do a quick round of introductions, starting with Katie Herman.
Thank you, Allie. So I'm Katie Herman. I'm a senior policy analyst here at the CSG Justice Center. I live in San Francisco. I've been working at the Justice Center and on this diversion program for about a year and a half. Prior to joining the Justice Center, I was working in New York City for a large agency that did a lot of diversion work that's really similar to the work that DSH is doing now. We had a program at my agency called the Nathaniel Act Team, which was the first alternative to incarceration program for people with felony charges and serious mental illness in New York State. That started 21 years ago. And we were really known as the agency that took on like the most difficult high-need clients in New York. So I worked there for about 8 years, both on the direct service side, but mostly on the court side. Then I transitioned to supervising staff on our court side. But this is really like a passion of mine, diversion for this specific population, and I'm really excited to be here and helping you all. And now I'll turn it over to my colleague, Joseph.
Thank you, Katie. Hello, everyone. My name is Joseph Hayashi. I'm a policy analyst here with the CSG Justice Center in the Behavioral Health Division. A little about my background. I come from a area of conflict resolution and working with local communities. With the Justice Center, I've been here for around 6 months now, and I've helped facilitate and assist on multiple projects around housing and incorporating racial equity in initiatives. And I am actually located in the Monterey County, and I'm really glad to be a part of this. Thank you. And I will pass it over to Rosemary.
Hello, everyone. My name is Dr. Rosemary Whiteshield, and I'm new to the Justice Center. I'm thrilled to be here and thrilled to be here with you all today. I'm a project manager with the Justice Center, and currently I live in Minnesota, but I'm moving to California. My areas of focus include bringing an equity lens to our efforts and also to help serve tribal nations. And my home base, so to speak, is in the Behavioral Health Division. My area is of interest and also expertise is culturally responsive behavioral health design and methodology. both in methodology and practice. And with that, I will pass it over to my colleague, Sheila.
Hi there. Thank you, Rosemary. My name is Sheila Tillman, and I'm a Senior Policy Analyst at the Council of State Governments Justice Center in our Behavioral Health Division. I've been at the Justice Center for a bit over 7 years now, and in that time have provided technical assistance to our Justice Mental Health Collaboration Program grantees. I've also worked on a number of projects related to the Stepping Up Initiative and data collection and evaluation and information sharing and sustainability. So very much excited to be joining you all today. I should say that I'm on the East Coast, so I'm joining you from the other side of the country in good old Connecticut. So thank you for having me today, and I look forward to speaking with you all later on. I'm going to pass it over to my colleague, Deirdre.
Thanks, Sheila. So my name is Deirdre Assay. I'm a Senior Policy Analyst at the Council of State Governments Justice Center. I've been here working with JMHCP grantees and other work for about 5.5 years. And prior to joining the Justice Center, I did both competency to stand trial evaluations as well as civil commitment evaluations, and also worked on a mobile crisis team. And like Sheila, I am joining you from the East Coast. I am in Virginia, and I will pass it to my colleague, Jennifer Casella.
And I think, Hallie, that we might be missing Jennifer at the moment.
You know, I think Jennifer is signed in as a participant. I don't know, or an attendee rather. I don't know if it's possible to move her over to being a panelist.
Let me find her.
While Ashley's doing that, I can talk about the next person we're really excited to bring to you all. We'll be working on this project with Dr. Deb Peinels, who is a forensic psychiatrist. She currently serves as the medical director for behavioral health and forensic programs for the Michigan Department of Health and Human Services. And Dr. Peinels has written and consulted with states and with communities, both on competency to stand trial as well as establishing mental health diversion programs. She's definitely seen as a national subject matter expert in this area, so she'll be joining us for a number of the Academy sessions to share her experiences and also answer questions folks might have where her expertise will be useful. Did we get Jennifer in?
I unmuted her.
Yeah, are folks able to hear me now?
Yes.
Oh, wonderful. Jennifer Casella, I'm a Deputy Program Director here at the CSG Justice Center. I'm with our State Initiatives Division and work primarily on our justice reinvestment projects, which intersect with all areas of the criminal justice system and frequently include overlap with the behavioral health system as well. I've been with the Justice Center for about 6 years, and prior to that worked for 15 years out of the state of Ohio in community corrections. I am based out of our Seattle office and have been throughout my career working in approximately 13 states that I've done technical assistance or worked in. One of my colleagues, Tracy Gillespie, is not with us today, but will be with us in some of the November trainings. She is a senior policy analyst, also based out of the Seattle area. She works in the State Initiatives Division as well on looking at the containment of correctional costs and reducing the need for community supervision revocations to prison. Prior to coming to the Justice Center, she was an operations director for the Seattle-King County Law Enforcement Assisted Diversion Program and also has experience in
reentry community safety programs and advocating for sexually exploited minors in King County. So happy to be with y'all today, and I am the last of the introductions from the Justice Center staff. So I will turn it over to Hallie if she has anything else. Thank you.
Sure, thank you. So just so you know, we are all really excited to get to know you and help you as you're putting together these diversion programs. And Ashley, am I introducing Dr. Desmarais, or are you doing that?
Dr. Desmarais is here. So I think we can pass it to her and let her introduce herself. Thank you, Hallie.
Fantastic, yeah.
Hi, everyone. Last but not least, I guess, on this side of the house, Sarah Desmarais. I'm a Senior Vice President at Policy Research Associates. I am a forensic psychologist by training and have been working with the Department of State Hospitals for over a decade now in various capacities, but very much focused on promoting positive outcomes for folks with behavioral health needs. I'll be talking with you all quite a bit about risk assessment in management and how to make sure that you're connecting those pieces to promote treatment outcomes and community and individual safety. So I'm really looking forward to getting to know you all a bit more, and you'll be hearing a lot more from me as time goes on. Thanks.
Thank you, Dr. Desmarais. So now we're going to turn it over to all of you out in the audience to introduce yourselves. So what I will do, how we will manage this is we will go county by county down the list and have each of your team members who are here with us today just give us your name and the stakeholder group you're representing. That would be awesome. And I actually would like to ask you all to test our little buttons that we talked about earlier and let me know if you all are able to see the microphone button that is next to your name, and if you are able to mute or unmute yourself. If it's a yes to that, and you can see that, if you can use the green check mark, and if it's a no, and you can't, if you can use the red, and I'm seeing some red. So I have a feeling I'm going to have to unmute all of you. So give me one moment. I'm going to run down the line and unmute everybody. And once I've done that, you should all, look like some of you maybe are. So give me one moment to unmute, and I will let you know when I'm done.
Testing.
All right, so we're getting close to the end here. And I think some of you may have found the button because some people are being muted and unmuted after I've unmuted you, so that's great. Keep running through this. All right. So I will let the folks who have muted themselves the second time unmute themselves when we get to your county. First county on our list is Madera County. Can our members from Madera County say hello and introduce yourselves quickly?
Hi, I'm Gloria Garcia from Madera County Probation.
Gloria. Any other members from Madera here?
Chris Rodriguez, Madera Sheriff's Department.
Hi, Chris. Welcome. Anyone else? Madera going once? Going twice? How about we move down to Nevada? Members from Nevada? Can you please introduce themselves?
Hi, this is, hear me?
Yes.
This is Phoebe Bell from Nevada County. I'm the Behavioral Health Director, and my team just voted to have me quickly introduce everybody who's here. We have Alicia Burgett from the Sheriff's Office, Carrie Yardley and Kelly Minergan from Behavioral Health Department, Jeff Goldman from Probation, Molly Legault from our CEO's office, and Micah Pierce from our Public Defender's office. And if I missed anyone else from Nevada County on that list, please chime in.
I am Linda Slovin. I'm a judge in Nevada County, and I oversee our mental health court and our mental health diversion cases, along with other things.
Thank you, Judge Slovin. So sorry.
That's okay.
Thank you, Nevada. San Joaquin County.
Hello, I'm Judy Anzalato at the Public Defender's Office.
Hi, this is Matt Garber with San Joaquin County Healthcare Services. Looks like we've got about 5 other folks online. I don't know if you guys can introduce yourselves.
Eric Taylor from the Public Defender's Office in San Joaquin County.
Jeff Derman from the San Joaquin County DA's office.
Casey Rain, also from the San Joaquin County DA's office.
Cynthia Borges from Correctional Healthcare, San Joaquin County.
Betsy Rose from San Joaquin County Behavioral Health Services.
Excellent. All right. Thank you, San Joaquin. Yes.
Sweena Pannu from the Public Defender's Office. Can you hear me?
Yes. Hi, Sweena.
Hi.
Birgit Flatiger, District Attorney.
Chandra Campbell with Stanislaus County Behavioral Health and Recovery Services.
Clifford Song from the Stanislaus County Public Defender's Office.
Oh, I'm sorry, go ahead. Anybody else from Stanislaus?
Jeremy Myers, Public Defender.
All right. Tulare County. And please correct me if I'm pronouncing your county names incorrectly.
Dr. Guerrero Claire from Tulare County Mental Health.
Hi, Erin Brooks from the Tulare County Public Defender's Office.
David Allen, in charge of the conflict attorneys. I'm an attorney.
Good afternoon. This is Dr. Elisa Huff with lead psychologist for Tulare County.
Welcome.
And Josh Beavers, I'm with Tulare County Behavioral.
And my name is Judith. Oh. I don't know if you can hear me.
Yes.
Yeah, my name is Judith. I'm with Tulare County Mental Health.
Janet Wise, DA's office.
Diane Higginbotham, Administrative Specialist with Tulare County Mental Health.
Hugh Swift, I see your note. I'm going to try to find you. Give me one moment. All right, Hugh, you are unmuted.
Okay, can you hear me?
Yes.
Okay, thanks. So, I don't know if you want me to introduce myself. I'm Hugh Swift. I'm the Court Executive Officer for the Stanislaus Superior Court.
Do that, and then I'll be right out.
Perfect. Thank you, Hugh. And it looks like we have one individual who we missed from Stanislaus. So once we finish with, let me see, one second, please. Sandra from Stanislaus.
Can you hear me?
Yes.
Hi, I'm Sandra from Stanislaus County Public Defender's Office.
Hi, welcome. All right, so Stanislaus, did we get everybody from Tulare? I'm sorry. All right, and Tuolumne.
Hello, Michael Wilson. I'm the Behavioral Health Director for Tuolumne County, and I was the former Forensic Manager in Stanislaus, so saying hi to all those folks.
Hello.
Cassandra Janicki, Tuolumne County District Attorney.
Welcome.
Dan Hawks, Tuolumne County Chief Probation Officer.
Others from Tuolumne? Let me...
Kelly Gorman is also present. She's one of our lead public defenders, and I think our CAO from the court, or our CEO from the court, Hector, will be joining us a little late.
Perfect.
Thank you, Cassandra. I was muted.
Sorry about that.
That's okay.
All right. Anybody we missed?
I also have some other behavioral health staff on. Betty Hoskins, Brock Colby, and Tammy Mariscal from behavioral health. They might be away from the computer.
Okay, perfect. Excellent. All right. Thank you all so much for introducing yourselves. And I'm just going to do a quick little housekeeping to make sure we've got folks muted just for the background noise purposes. And we will get going with the rest of our presentation. It was really great meeting all of you. We're really excited by the turnout today. So glad that you could all be here. And we hope to see you all, of course, throughout all of the sessions that we will be hosting over the next couple of months. So I want to start off the core of today's session by talking about some of our project goals and the different processes that we have in place to move you through the planning process and into, contract execution and program implementation. And before I get into all of those administrative pieces, I wanted to briefly review the core kind of goals of our program. I mean, these are really important because this is really the bedrock of what we're doing and why we're doing it. And these goals are going to be the framework and the lens that we here at DSH will be using when we are working with you and looking through the program plans that you submit to us for consideration. And so I'm just going to read over these quickly here. So our first goal is we would like to demonstrate effective strategies and community-based programs that can support the diversion of IST clients with a current felony or individuals who are at risk of an IST finding who have a current felony charge. We would like to certainly reduce the number of felony IST referrals to DSH. And ultimately, we want to use this program to begin integrating individuals into long-term community treatment after their diversion program to reverse the cycle of criminalization that we see a number of these individuals cycling through. So to reach these goals, DSH developed the diversion program, which provides funding to participating counties for 3-year pilot programs. This table outlines the client and kind of program eligibility criteria for the 3 different funding pathways we currently have for the diversion program. The eligibility criteria for you all for this particular group is in the center column, the new county fiscal year 21-22 funding. So we started off with our 18-19 funding, which is the far left column. And what you'll see there in the kind of the basics of eligibility and requirements for this program, the clients that are diverted should be IST or likely to be IST as determined by the county. The individuals must have a diagnosis of schizophrenia, schizoaffective disorder, or bipolar disorder. The county is required to provide a county funding match. The county has to establish nexus criteria between the alleged crime that an individual has committed and either the symptoms of their psychotic disorder or a condition of homelessness, and have to determine that the folks who are participating in their diversion program are reasonably safe to be treated in the community. And so for you new counties coming in fiscal year 21-22, you have the exact same requirement. So the program that we are going to be moving you into is a mirror to our original 18-19 pilot program. And the last column is really, I think, just more for your information. As part of our funding that we received this year, we also have some funding to expand on the counties who are already contracted with us for this program. And we have there's a couple changes for those expansions, most notably that they are required, if they take the expansion funds, to use those dollars to divert ISTs only, so ISTs from our wait list, and those ISTs can have any diagnosis that's allowed under Penal Code Section 101.36. But for you all, we still have, I guess, what we could call diversion classic, with the 3 diagnoses: schizophrenia, schizoaffective disorder, and bipolar disorder. And you are able to divert individuals who have been found IST or who your county feels are likely to be found IST if they were to have an IST evaluation conducted. So the program plan, that's probably the biggest piece of everything that you'll be working on with us in the next couple of months. For your cohort, we developed a program plan template, which is a fillable form, and that is really going to be the program plan that you keep on record with us here at DSH. That document is to be completed and submitted to us by close of business on Friday, December 17th of this year, 2021. And yesterday, I sent out an email to my main contacts, and I think the majority of you who are here today hopefully got a copy of that email. It does have attached to it a number of documents, including the program plan template that I'm speaking about right now. And I do want to take a moment to give a big thank you to our friends over at CSG for partnering with us and really leading the charge on getting this program plan template developed. Without their hard work, it would not exist. So I am very grateful to them, and we hope that you all as counties find this a helpful element in putting your program plan together. So this plan template is going to correspond to the county planning guide, which is a document that was also developed by CSG and was part of the materials that I sent out. You can use that planning guide to help you complete your program plan template. As well as, each of our 5 academy training sessions will be focused on helping you complete certain parts of that program plan template. And we will be having breakout sessions in each of these training days for you all to work on drafting, or at least starting to talk through different sections of that program plan. As an additional support, we will also be offering one-on-one sessions with all of you, primarily in October and November, and that will be with CSG and us here at DSH to help work, and Hallie kind of alluded to this earlier in her introduction, to help you work through any specific problems, barriers, things like that you may be having to completing your program plan, things you have questions about, or areas where you maybe need just a bit more assistance. These one-on-one sessions are totally optional, so you do not have to take advantage of them, but it is something that we will be offering to you all. And then just to let you know how things will go from there, once you submit your plan to us in December, we here at DSH will begin reviewing, and then we'll work directly with you to clarify anything, any information that we have questions about, and make any recommended or make recommendations in terms of any potential adjustments to your plan. Once we've gotten through all of that, you will receive a formal email from us that we have approved your plan. And because this is a pilot program, I also want you all to know that your program plan is not written in stone. This is a pilot, so we anticipate that as you move through this project, you likely will have parts of your program plan over time that need to be adjusted. That's how this works. So what we ask is that when you have a major change to how your program is operating, that you update your program plan document and submit the new version to us, and we'll go through kind of a similar process where we will give it a quick review, see if we have any questions or need any clarification, and then we can, approve that updated program plan. Our intention with that, of course, is not to slow down your program or, create any unnecessary red tape to you making adjustments to how your programs are functioning. It's really a speedy review process at that point, and it's just so that we're keeping track of how the programs are running and what the designs are. So I think I've given you probably quite a bit of information over the last couple of slides, so I'm going to pause there for a second and see if anybody has any questions. And you can use like I mentioned before, the raise hand button to indicate that you have a question, or you can type into the chat. And I see one raised hand, Ellen Schwarzenberg. I'm going to unmute you and see, Ellen, can you hear me?
Yes. During the course of the grant, are there going to be specific meetings with regard to any changes if we need to implement changes, or is it done on a less than formal basis?
It's typically a more informal basis. We can certainly meet with the teams if that's something that you all want. We regularly are in contact with all of our county programs to even just, brainstorm potential solutions to problems. But there isn't a formal process like this, like what we're doing now. Once you have that initial program plan in and approve the changes, you can basically do tracked changes in your program plan document and submit that to us via email, and we will, read through it on our end, get back to you with any questions, and then go from there. Does that answer your question?
Yes, thank you.
Perfect. Okay, I'm scrolling through. I don't see any other raised hands, so I'll go ahead and move on to our next slide. So the DSH diversion contract and the contracting process. So as part of the materials that I sent out yesterday, there was also a contract template. It's a master contract template for this program. You all received the exact same version, which because it's the master template, it does not yet have any of your county's specific information entered into it, so you'll see that as you review that document. All of your county specifics will be entered into the contract template in December after we receive your program plan. However, to help expedite our contracting process and kind of run contract review in parallel with program development, we are asking that your team share the template with any of your county stakeholders who will need to review and approve the contract language in the contract itself with us. And so they can submit any questions or concerns or comments they have about that language to DSH when you are submitting your program plan to us. This is a process that we used with our initial round of counties in 1819, and it really did help expedite the contract process because, the program planning process can take a number of months, and I think most of us in government know that the contract review process can take a number of months. So if we can do those simultaneously, it really helps move things along. Once we have any questions, comments, concerns from your county stakeholders, DSH will review that, you know, we typically have a mix of contact over email. We can also often will set up meetings and calls to discuss county concerns with the contract language and kind of just work through any issues there may be. And then we will have all of that kind of, I guess, tied up by the time we get to the point of actually executing the contract and sending a version to your counties for final signature. Our goal for this cohort of counties is to have all of your contracts executed with a start date of July 1st, 2022 and an end date of June 30th, 2025. But if your county will need to adjust those dates, we can have discussions about that when we're finalizing the contract details for execution. That's not set in, so I guess to say those dates aren't set in stone, that's just kind of what we're working with now. That's our goal for the time being. And as your program plans develop and you get a better sense of your timelines, we can have conversations about what the contract start dates should be. So I'm going to pause again and see if there are any questions about the contract process at this point. Now, Ellen, I see your hand is up, but I'm not sure if that's a new hand up or if that's from last time.
Old hand. It's an old hand.
Old hand. Okay, perfect. And I will pause at the end of my presentation to take questions on any of these topics. So if you don't have a question right this second, don't worry. There will be time at the end as well. So I'm going to go ahead and move on to the next piece of this, which is our program budget. So your team also received in that package from me yesterday a program budget template, and that's something that is submitted along with your program plan. It's technically part of your program plan, but it's just a separate document. We used an Excel format for that. And the purpose of that budget is to reflect your best estimate of what the full cost of your program is going to be. It should identify where you will be using DSH funding to support your program. It needs to identify what form your county match requirement will be made in and how those funds will be used, and then identifying and estimating any other funding sources that you will be using to support the program. So a little bit about the county match. Depending on the size of your county, you will be required to provide either a 10 or a 20% match in funding, and that does have to be local county funds. It can be a cash match or it can be an in-kind match, so we have some flexibility there. And some of the county funding sources that are acceptable for this program would be county general fund, your local MHSA dollars, 1991 realignment, 2011 realignment, et cetera. The other types of funding sources that you may be able to draw down to help support this program and that we've seen other counties pull on would be sources such as Medi-Cal, SSI, SSDI. If you have any specific federal grant dollars that could be applied to a program like this, or other state grant dollars. And these additional funding sources, just to be clear, they cannot be counted towards your county match. They are separate from your county match. So for submitting your program plan budget, we are going to ask that you use the template that we provided, if at all possible. And one of the reasons we ask you to do that is because it's actually a match to the template that we use for your required fiscal reports. So as part of your contract with us, we are requiring that you submit twice yearly fiscal reports to the department after you start drawing funds from us. You don't have to report anything until you're actually pulling funds from us. But we have two main purposes for this. First, we do need to make sure that each of the counties is meeting the required match for the program. And as far for our sake, or I guess as far as we're concerned, you could meet your county match in the last 6 months of your program, and that's fine. We just need by the end of the program through the fiscal reports to see that the county match was made in its entirety. And we also are going to be looking at these reports as a way to really analyze the costs of treating this particular target population out in the community. You know, if you try to look for community costs for individuals who have serious mental illness and criminal justice backgrounds, it's difficult to really find, I think, good numbers on what those costs are. So we're hoping that this pilot project can help us understand what those costs are, or better understand what those costs are here in California in different parts of our state, different types of communities. I also want to note that we are not going to use these reports to reclaim any unused funds from the county. So if you have funding, I guess, left over, so to speak, from our DSH pot that you have been allocated by, that we've allocated to you that you haven't used, we aren't going to be reclaiming those funds at the end of the pilot. However, we would like to see that you increase your program population goal if you have the funding to support it. So that's something that we will be tracking through the fiscal reports, and also something that we'll work with you one-on-one to make sure that, you know, if you have extra funding, that we can put more people potentially into the, who, as long as they meet, you know, the safety and other eligibility requirements, we can get more people into those programs. I'm going to take another quick pause for questions before I move on. Okay. So now maybe one of the more important questions, how do you get money from us for this program? How does the funding work? So unlike other programs, your county is actually not going to bill DSH for the actual services you provide, and you will not be sending us an itemized invoice along with each of your payments. That's not how the funding mechanism in this project works. Instead, we have put together a deliverables-based contract, and we pay you for reaching specific program population benchmarks, which I will talk about a little bit more on the next page, or the next slide. So the majority of these program benchmarks are tied to the number of clients, the total number of clients you have served in your program. Your invoice verification for this project is actually going to be a very short data sheet that you will use to report on the clients that you are claiming for your specific, whichever benchmark it is that you are billing us for. And it's going to include data elements about those clients that we need to verify that they meet all of our eligibility requirements. So typically, we recommend that you first submit the data verification to us for review in case there are any issues or questions that we have with the clients that you're submitting to us. And then once we let you know that we've cleared the data, then you can submit your invoice to our accounts payable office. One thing I do want to note, and this is something that of course we will repeat in the future, but we have a secure file transfer system that we use for this program, and anything related to patient data needs to be uploaded through that system. So when it comes to invoicing the department for clients, any client support documentation should be submitted through that secure system and should not be submitted with the invoice to the accounts payable office. So the funding distribution for this program. So our general payment structure is a six installment payment for this project. The first 25% of your funding will be allocated to you for implementation costs. So those can be costs for things like So you have to procure a master lease or pay some kind of down payment on a lease for housing. You're hiring and training new staff, like all of those upfront costs that come with launching a program like this. To bill DSH for this particular benchmark, basically you need a executed contract, and the deliverable is having your approved program plan and budget on file with DSH. So once your contract is executed and we have approved your program plan and budget, your county can invoice us for that first 25% of funding. The remaining benchmarks are all based on admitting and serving a certain number of clients into the program. So I'm going to kind of do a little explanation, and to make it easy, I'm going to say, let's say you are contracted with us to serve 20 clients over your 3-year pilot. So you, with a 20 client population goal, can bill DSH for your second payment installment once you have 2 people, or 10% of that population, in your program that meet the following conditions. So each individual must meet all of our program eligibility requirements, so the diagnosis, the felony charge, etc. They need to have been in your program for a minimum of 30 days. You need to make sure that they are somebody you have not already counted towards a prior benchmark, so we will only count each person in your program once. And we also make sure that the clients have not already received any form of restoration services from DSH, either in a state hospital, a JBCT, CBR, or AES, for their current offense that they're facing now. So they could have, you know, obviously we all know that we get a lot of folks who cycle through these systems, so you may have an individual who is in your diversion program who on in a previous incident, a previous charge, went to DSH for services. That's fine. If on their current charge that they are facing for which you are wanting to divert them, they have already been admitted to DSH in one of these other ways and have received services, they aren't going to be eligible for funding from us. You can still divert them, but we will not be able to pay you for those individuals or count them towards your funding population. And I did get a question in the chat, so I will take that. When you say you do not count them more than once, does the 20% client count include them? Yes, so it's a cumulative count. So using the example of the 20 individuals, so installment 2 would be 2 people. Oh gosh, I may have made this too hard on a Friday for my math, but let's say your next installment, you'd need 3 more new people, because 25% of 20 would be 5, correct? So you'd have your first 2 people in installment 2, and then you get to 5 people for installment 3 because you've added. I'm sorry, I'm probably making this more confusing now. You've admitted enough individuals to meet the next level of your installment, and it'll be mapped out in your contract. I also want to add that for some of our smaller counties here who are looking at pretty small patient populations, we will work with you to adjust these installments, because for you 6 installments is not going to make sense. So this is just the baseline that we start with, and we will work one-on-one with your county if you have a much smaller patient population that you will be serving, so that we can, so to make it easier and make it so it makes more sense for the smaller counties. All right, any other questions about this before I move to the next slide? I'll go through and see if I see any hands raised, and I do not. And just a reminder, you can also put questions into the chat. Okay, coming to the end, and a break is imminent, I promise. So really quickly, I want to touch a bit on the program data collection process for this project. As part of your participation, you will be required to submit quarterly client data reports to us once you have started admitting patients. Those quarterly reports are due 90 days after the close of each quarter, and we do use the state fiscal year for our quarters. So for example, quarter one of any year would be the months July, August, and September of that year. We sent you a master data dictionary in the packet of materials yesterday for you all to take a look at. And once you are contracted with us, what we'll have you do is have you identify who in your county is going to be responsible for collecting the data and sending that into us. And we will set up a meeting with them, any other stakeholders who need to be involved in your county, and with Dr. McDermott and her team. And what will happen during that meeting is you'll basically go line by line through that master data dictionary, and with Dr. McDermott, create a county-specific version of the data dictionary for your county. And that, in turn, will be turned into either an Excel file for data collection that will be sent to you, and that's what you will use to submit your data to us, or Dr. McDermott has also created I'm gonna blank on the word, but she basically created some fillable forms that you can also fill out, which a lot of our counties that have much smaller patient populations prefer to use. So you will be able to choose which method of data collection works best for your county, and we'll work with you there. One thing that I do want to mention, and I'll talk a little bit about this on the next slide too, is when I say that we're going to kind of adjust the data dictionary, we cannot take out any of the core elements of the data dictionary. We are required by law to collect the data we are collecting. What we will do is, if for instance, especially in the services portion of the data dictionary, there are a lot of questions about the types of services you're providing, and there may be 5 or 6 potential responses to a certain data element. And if your county is only going to provide 3 of those services, then in your data dictionary, we'll get rid of the ones that aren't applicable to what you are doing. I hope that kind of makes sense. And it's certainly something that you will have more time to go over in more detail with Dr. McDermott in the future. And again, as I mentioned, we have a secure file transfer system that we use, and that's how you will be submitting your data to us. So on this slide, we see the statutory data requirements for this program, and this is pulled directly out of Welfare and Institutions Code 4361. And the data dictionary that was sent to you was developed to operationalize these requirements. And in essence, these are the elements that you are required to report to us, and we are required to report to the legislature. And I will say any and all reports that we produce that are shared with the legislature and the public will be properly de-identified. We recommend that your team review the master data dictionary and determine who will be responsible for submitting your data to DSH, and to think about if you, for instance, need to put in the MOUs or data sharing agreements in place in your county to collect the various data pieces that you will need to submit to us. And I want to be sure to give you guys as much of a break as possible. So I'm going to quickly run over our department letter process, and then I'll pause for any last questions. So the department letters, this is an administrative process that we use. We are allowed to do this through, again, WIC 4361. And we use this process to clarify policy and procedures for this program. Currently, we have 2 active letters, which you all were sent a copy of. The first outlines our authority at DSH to collect all of the data contained in the data dictionary. And the second provides additional clarification on the eligibility requirements for participants that we will fund through this program. We will in the future ask each of your teams to identify the stakeholders that these letters should be released to. And then those stakeholders in turn would be responsible for ensuring that all necessary parties in the county receive that information. As you move through our project, we have lots of different forms of ongoing support. This is just a small list of the different support services that we have. We do a monthly office hours call. It is totally optional, but all of our counties are welcome to participate, and it's really just a roundtable discussion of where the counties are in their programs. Right now, most of the ones, basically everybody who's participating in this now has an active program, so they're able to ask each other questions and learn from each other as they come across different barriers and challenges, and also celebrate different successes. So it's a really great call. We do quarterly all-county meetings where we provide typically some direct TA, as well as some, again, connection of the counties to discuss current opportunities and challenges, and help provide solutions for the counties. We have developed a SharePoint site for all of our counties to network on. And then we also do a number of different webinars. As we identify, or as counties identify for us, different areas where some training and technical assistance is needed, we have contracts with various partners to help us provide that necessary training and technical assistance. And you can find a lot of the webinars that we've already given over the last 3 years on our DSH Diversion webpage. If you haven't visited that page, I would really recommend it. We have a number of pre-recorded webinars up there for you to peruse on all sorts of different topics. We also have access to other documents and reports and things of that nature that are that help with developing a diversion project. I also wanted to give you the web address for the Council of State Governments Justice Center. They have an excellent resource page as well. And if you have questions, you can, of course, always reach out to us at our DSH Diversion email address there. So before we move on to our break, I'm going to pause and see if there are any questions. I got a couple questions in the chat about the PowerPoint. I will send you guys a copy of this PowerPoint when we're finished here today. Just we're putting some finishing touches on it this morning, so I wasn't able to send it out yesterday with the other package of materials. And we are also, I will say, recording this, and we will make this recording available to you all in the near future. We will be recording each of the sessions, and we do ask that any team members who are unable to participate with us live rewatch the sessions. Unfortunately, this platform will not allow us to record the breakouts that you have with your county, so we won't be able to share that with them, but they will be able to get the larger presentations that we are providing. All right, so it is a little bit after 2:15. Dr. Warburton will be with us at 2:30 to start her presentation. So if you all can be back in, I guess it's about 12 minutes, that would be wonderful. We will see you in a bit. All right, everybody, it is 2:30, and I'm about to turn things over to Dr. Kate Warburton. Before I do that, I just want to ask everyone, I entered some names into the chat box while we were on break. I have some folks who registered who I wasn't able to put into breakout rooms, pre-assigned to breakout rooms yesterday. So during the presentation, could you please make sure to just let me know which county you are attached to so that during our next break, I can make sure to get you into the right breakout session when we get to that point. And 1 second. And I will say, I'm going to apologize, it was in poor form. I didn't realize my camera wasn't on during that whole last hour, apparently. So I apologize, I will be better in the future about that. But now I am going to go ahead and turn things over to Dr. Warburton.
Thank you, Ashley. Can you hear me okay?
Yes, we can.
Great. So my name is Kate Warburton, and I'm a forensic psychiatrist, and I'm also the medical director for the Department of State Hospitals. I've been with state hospitals my entire career, starting on the units at Napa State many, many years ago and being chief of forensics there, and I've been in my role for over 10 years now, I think. So this diversion project is probably the most important initiative that we've launched in my career. And I hope after I finish this slide deck, you'll understand why. Next slide, please. Overutilization of state hospitals is a historic problem, not just in the United States, but all over the world. Over-institutionalization, under-resourcing, and overall neglect of people who have serious mental illnesses is cyclical throughout history. We've read the entire history of psychiatry, and we've yet to find a sustained period of time where people who have psychotic brain diseases have been well cared for holistically and compassionately, except for perhaps one small city in northern Italy. We've yet to see this happen. And so what happens instead is overutilization of institutions for people who have serious mental illnesses. Starting in the 1850s, that was in the I'm going to just do the United States here. That's when asylums or state hospitals were built in this country. And that was in response to just pretty horrific conditions that people with serious mental illnesses were living in. So there's lots written about individuals being kept in cages, locked in jails, chained to walls throughout the world prior to the mid-1850s. In response to that, there was a movement to create a more humane environment for people who have serious mental illnesses, and this was the advent of the so-called asylum. And if you read what the mental health policy leaders at that time had to say, they were congratulating themselves for having finally solved this problem. And they built these beautiful Gothic castles and delivered what was called at that time moral treatment, where people enjoyed nature and quiet and received compassion, did gardening, and oftentimes got better. Unfortunately, those asylums quickly became overcrowded. 50 years later, there were less than 2,500 patients in state hospitals nationally at that time. 50 years later, there were over 150,000 people in state hospitals, and 50 years after that, there were over 500,000 people in state hospitals around the country. But they didn't build new facilities to accommodate the 500,000 people. The 500,000 people were put into the facilities that were built for the 2,500 people. And so you've got really horrific, overcrowded, under-resourced conditions in the middle of the last century. There's been exposés written about it. I have a series of newspaper articles from the 1940s to the 1950s about the California state hospital system and how horrible and inhumane the conditions were at that time. And my argument to you today is we are headed right back into that same path as we head into the middle of this century, only this time we're going to it using this forensic pathway or the IST commitment. Just academic papers here in white to augment some of the overcrowding data. In 1923, a psychiatrist named Lionel Penrose wrote a seminal paper that's still quoted today, where he studied a variety of different societies and found that those societies that have high numbers of individuals in their criminal justice system have lower number of individuals in their mental health system and vice versa. Those societies with a lot of people in the mental health system had fewer people in the criminal justice system. And this is known as the Penrose theory or the balloon theory. After the awful abuses, at that time, in the 1950s, at that time, state hospitals were referred to as snake pits. The very noble and well-intentioned effort of deinstitutionalization began with the rewriting of commitment laws, the advent of antipsychotic medications, and a will for lawmakers to do something about the overcrowding in state hospitals. It's one of those interesting situations where all lawmakers seem to agree, whether fiscally conservative people not wanting to bear the expense of refitting asylums to accommodate the 500,000 people in them, or more civil libertarian-oriented lawmakers wanting to have people treated in the community. Everyone sort of agreed that deinstitutionalization was a good thing, but unfortunately deinstitutionalization was not resourced appropriately in terms of building out the community resources. And by 1972, psychiatrists were starting to sound the alarm in the literature. There's psychiatrist Dr. Abramson, who actually practiced here in California, started working after the closure of state hospitals, started working in a jail, and noticed that many of his patients from the state hospital were winding up in his jail. And so he did a little study and found that in his county, there had been a 100% increase in mental health arrests from 1968 to 1978. Zasowski in 1978 did a very similar project, finding that the former state hospital patients had higher incidence of arrests. And there's lots of this, in the literature, but I'm just pulling out some of the more interesting ones. Most interesting to me is a paper from 1988. So what was that, 31 years ago? Like Ashley, I'm not great at math on the fly, but this paper started examining the nature of the IST commitment and its potential to become a civil commitment. And I'm going to argue to you today that's exactly what's happening, although it's a commitment that does no one any good, and I hope I can convince you of that by the end of the talk. And in 2010, Fuller Torrey wrote a very widely read policy paper talking about how more mentally ill persons were in jails and prisons than hospitals. And I think everybody on this call, if you have the interest in this topic enough to be on this call, has heard about the statement that the 3 institutions in the United States that house the most psychiatric patients are all jails: Rikers Island, Cook County, and Twin Towers in LA. Next slide. When this started happening, we started reaching out to national partners, trying to find some data when we started experiencing the IST surge. And back then, there really wasn't a lot of national data to be had. The best we had when we first started looking at it was this slide, and this comes from the Nashville Research Institute. Ted Letterman, who's done a lot of work in this area, a great researcher. And he just sent us this, which showed that while there was no quantifiable data out there about the number of people in state hospitals, there was a real big increase in the percentage of state mental health authority budgets that were going towards forensic spending starting in the early 90s. Next slide, please. Nashville, a related institution, also did a study in 2014 just asking states if they were seeing increases in forensic populations. And 3 out of 4 said, yes, we are. And 78% were starting to maintain wait lists. And at that time, half of states were being threatened or being found in contempt of court for not admitting forensic patients in a timely manner. So this is 2014. I just want to note, this is when the crisis in California really started. We were doing okay until 2014. Next slide, please. So these are just newspaper headlines from around the country that illustrate the same problem that we have here, which is if your referrals for incompetent to stand trial patients are increasing and you can't keep up with the increasing demand, human beings end up backing up into jails, waiting to come into state hospitals, and probably the worst place for someone with serious mental illness is in a jail. And this is just to show you we're not alone here. Next slide, please. Finally, in 2017, this report came out. This was very, very helpful to us because the Nashville Research Institute was able to get some actual quantitative data that gave us a number, and that number is that the number of forensic patients in state hospital point in time increased from 1999 to 2014, increased 74%, and the number of incompetent to stand trial committed patients in state hospitals from that same time period rose 72%. So that's 99 to 2014. Just want to remind everybody that the real crisis started around 2014. There's no data yet, but I expect when those data come out, it's going to be pretty explosive growth. Next slide, please. And like everything here in California, we do it bigger. So this is just, again, NASHPD state profiles data showing the number of forensic inpatients, so the number of forensic patients in state hospitals around the country. And here in California, we have 44% of all the forensic inpatients in the United States. If you take the next 4 highest states combined, which is Florida, New York, Texas, and Georgia, that's only 36% of all the forensic inpatients. You look at all the other states, and that's only 20%. So while this is a national problem, in California, it's even bigger hurdle to deal with. Next slide, please. We look to Washington State to try to understand what's going to happen with the IST crisis. Washington State experienced the first litigation for their issues getting in incompetent to stand trial commitments into their state hospital system for very similar reasons that we've experienced. And so they were involved in this lawsuit, True Blood, and in 2015, that decision, federal court decision, said you need to get people in within certain timelines. And in Washington State, it was 7 to 14 days. And if you look at this data slide and the black bar across the top, when this decision came down in 2015, the Washington State Hospital System was getting about 3,400 referrals a year for competency services. By 2019, that number jumped to 6,115. So they are given a mandate to get people in quickly in 2015, and 4 years later, the referrals have nearly doubled. So it's an almost impossible formula for state hospital systems when you think about how difficult it is to build a state hospital bed, even if you're building and admitting and treating as fast as you can. You just cannot keep up with those numbers. I just want to point out that the last data point, unfortunately, does not reflect an improvement in the referral rate in Washington State. It just reflects the impact of the pandemic on courtroom proceedings and subsequent referrals. Next slide, please. So what happened in Washington? Well, they just couldn't do it. They could not keep up with that almost doubling in IST commitments and meet those federally mandated timelines. So they accrued over $100 million in contempt fines. It's just not, it can't be done. So now they have a different settlement agreement after that experience. And the new settlement structure up there in Washington supports improved access to appropriate behavioral health services that are designed to dramatically reduce the number of people entering the criminal court system. And that's the answer, is if we want to reduce the number of people waiting to get into state hospitals as incompetent to stand trial, we have to stop creating people with serious mental illness who are then found incompetent to stand trial. And I just really loved this quote from their secretary in Washington, Cheryl Strange, who said, "How we care for those with behavioral health disorders is a measure of our humanity as a state. Our work as a state, county, and local partners is never done." And that's my plea to you as well today. Next slide, please. So here's our numbers, and as you can see, we have similar trends, not quite as bad in terms of doubling, but in 2014 we had about 2,900 referrals for competency services, and by 2019 it was up to 4,500 referrals for competency services. And the same artifact from the pandemic is there in 2020, where we did see a decrease in referrals. But you can see, because we had to halt and then very much slow down admissions to comply with infection control practices throughout 2020. The orange bar across the bottom is our wait list. And so you can see, even though referrals were down a little bit in 2020, you see the impact of our wait list jumping from 844 people in 2019 to 1,428 people by 2020. And I hate to tell you, but it's over 1,700 people now. Next slide, please. We've tried, especially some of the people on Ashley's team and that whole division have tried to increase our capacity, and we've added over 1,000 beds to a state hospital system. You know, this breaks my heart. I'm a state hospital person, but the last thing in the world we want to be doing is institutionalizing more people with serious mental illnesses. And adding over 1,000 state hospital beds means something is going wrong in terms of mental health policy. Next slide, please. We've also increased the number of people we served. We decreased our length of stay. And while we were able to serve 3,900 people in 2014, by 2019 we were able to serve over 6,000 people. But it doesn't matter. The wait list just keeps growing. Referrals just keep growing. Next slide, please. So the question became why. You can't solve a problem if you don't know why it's happening, and so I'm going to run you through some of that information right now. We have the incredible good fortune of a long-standing research relationship with the University of California, Davis. There's a research professor over there named Dr. Barbara McDermott, and I would argue she is the premier clinical researcher in state hospital and forensic populations in the country. She's been studying this group for over 20 years. And in 2008, when I was still at Napa and the forensic chief, she started a research project to kind of answer a question, which is, who are these people incompetent to stand trial? And so we started just looking at them, and she and her research team would interview every single IST admission that was possible to interview, and she started collecting data, and she continued this project for years. The sample's huge. That particular sample of the people she interviewed at Napa was about 4,000 people. And then we realized we kind of needed to expand our sample, and so we did sort of about 400 statewide using a similar protocol, sort of validated that her findings could be extrapolated statewide. And for the last several years, we've just been coding some of the packets. So this has been ongoing research for the last 13 years. Next slide, please. So her original sample, this is representative of that original sample that I was telling you about at Napa. And one of the things they do is a malingering screening. And so malingering is the feigning or exaggeration of symptoms, in this case to avoid criminal adjudication. And one obvious question is, are more people symptoms to the crisis? But as you can see, the malingering rate has bounced between 15 and 20% or so over time, and that is not, does not explain the IST crisis. Next slide, please. This is an interesting category of people coming in already competent. There's a lot of people who can come into this group. What she would do is a screen for competence at admission. And it not only didn't go up, but it went down. So if it didn't go up, it means more inappropriate referrals aren't happening. What that means is these are individuals who have serious psychotic illnesses who are involved in the criminal justice system, not just people who are being found incompetent who shouldn't have been. We also used this to indirectly get at one of the early questions, which was, is this explosion in IST referrals related to methamphetamine use? And our hypothesis is that if that were true, we would see the number of people coming in as probably competent go up, because what happens with individuals who commit a crime when they have a methamphetamine-induced psychotic illness is they usually clear up in jail before they come to us. The psychotic symptoms resolve and they arrive competent. So our feeling is if this were being driven, if the crisis was being driven by an increase in methamphetamine abuse, we would see this number going up, not down. Next slide, please. This is just the brief psychotic rating scale, looking at are people more or less psychotic over time, and it didn't change in any way that would explain the IST crisis. Slide, please. These are just diagnoses, and as you can see, the blue bar at the bottom are substance disorders, and that didn't change appreciably. The top two bars, the yellow bar and the purple bar, are psychotic disorders. It's a very interesting thing how it has that mirror image, and we think that's because in 2012, around that time, the DSM-5 came out and kind of changed the way that we diagnose and what we call psychotic disorders. So there's that interesting mirror image. But if you add them together, the number of percent of individuals coming in with a psychotic illness hasn't changed, and it represents the vast majority of people being committed to us as incompetent to stand trial. Next slide, please. So this was the first indication of change in terms of the overall population coming to us as incompetent to stand trial, and this is what got our attention initially. And this just shows the percentage of individuals that we're admitting over time who had 15 or more arrests by the time they had their instant offense and came to us. And Dr. McDermott did this by looking through their criminal arrest histories. And that number, the percentage of people that we were admitting as incompetent to stand trial in fiscal year 10-11 was around 16%. And by fiscal year 14-15, it was up around 46%. So in that short span of time, the criminal arrest histories of individuals who were being arrested as incompetent to stand trial pretty much just exploded. And what this really means to us when you look at the fact that it hasn't changed appreciably is that more and more individuals who have psychotic disorders in California are experiencing criminal justice contact. Next slide, please. So when we started looking through that data, we started looking through the arrest reports, and a lot of the arrests were trespassing, minor misdemeanor offenses combined with battery on a police officer or resisting an executive officer. And we started looking at police reports, and we started seeing this kind of typical story of an individual who was unsheltered, symptomatic, getting in trouble with the police, having some kind of altercation at the time the police arrived, and getting arrested on charges related to that altercation. And so that smaller sample I told you about where we went out statewide in 2016-17, we started looking at the issue of homeless status. And in that first sample we did, we were stunned to find that 47% of the individuals that we're admitting as incompetent to stand trial were in an unsheltered condition at the time of their arrest. Not living in a shelter bed, not living in a car, but like living on the open street unsheltered. And when you compare that to 0.199% of people in California compared to 47% of the ISP population, it's pretty remarkable. There's been an ongoing coding process looking at ISP admission packets since 2018, and over 4,000 packets have been coded. And that coding process looks at all homelessness, not just unsheltered. And when you consider all homelessness statuses, it's 65% of all the people that were admitting as incompetent to stand trial are homeless at the time that they're arrested on the incident offense. Next slide, please. Then Dr. McDermott partnered with DHCS and took that same sample and tracked them back through Medi-Cal utilization data to see what kind of mental health services these individuals were getting prior to their arrest, and found that 47% of them had no Medi-Cal reimbursable mental health services at all. So these are individuals who are psychotic, they are homeless, and they are totally untreated. Those that did get mental health services was mostly in the emergency department, not some full continuum of care in the community. Next slide, please. So then we did a national survey to see, and this we did in 2017, to see if what we were experiencing in California was happening nationally. And we sent it out to all 50 states as well as the District of Columbia, and we got 50 jurisdictions to respond, which is a fantastic response rate. And these are the folks that filled out the survey. The red wedge is usually the forensic director of the state, which is a role that we don't quite have here in California, so we did an oversight when we designed the survey. But in general, it's the people leading the mental health service or the forensic service in that particular state filled out our survey. Next slide, please. I have a whole hour plus on the results of the survey, but the upshot is that 78% of the respondents were seeing referrals for competency restoration increasing. And there's lots of nuances because some states do evaluation and restoration for competency, and when you add those together, it's a lot. But just looking at restoration services, 78%. And as you can see, no states reported competency restoration referrals decreasing in this survey. Next slide. And at that time, so this is 4 years ago now, 71% had a wait list and 39% were facing litigation. I'm sure that pink litigation bar is much higher now. I know we answered no on that in 2017, and we would answer yes on that in 2021. So this pattern that we saw with True Blood versus Washington up in Washington State, it's happening all over the country. Next slide, please. So we just asked for opinions on what do you as the mental health leader in your state think is driving the IST crisis? And these were the top 4 answers. Inadequate general mental health services in the community, inadequate crisis services in the community, inadequate number of inpatient psychiatric beds in the community, and inadequate assertive community treatment services in the community. These are just the opinions of state leaders around the country as to what was driving their IST crisis. Next slide, please. So I asked why at the beginning of this portion of the presentation, and I'll tell you based on all the research that we did, this is our hypothesis. Individuals who are living with schizophrenia spectrum disorders are drifting into an untreated, unsheltered condition. These conditions are leading to increased criminal justice contact with police and criminal charges. This increased contact is leading to a surge in people being found incompetent to stand trial, because if you have someone with a psychotic disorder being arrested more, you're going to have more people incompetent to stand trial. And this is what's responsible, in our opinion, a most likely hypothesis for why we've had this IST crisis. Building more state hospital beds is only going to exacerbate the problem long term. I would harken back to my initial slide. We have kind of one of those dark humor jokes in state hospitals, a field of dreams. If you build it, they will come. But when you build out mental health capacity on the wrong side of a felony, this is what happens. You have more and more people getting arrested as the patient population diffuses towards the treatment. IST restoration is not adequate long-term treatment planning. This is a very, very important point. If somebody made a decision that state hospitals needed to treat all individuals who were unsheltered and untreated in California, I would be delighted to do that. I care for this population very much. But instead, we just teach them what a judge is. We stabilize their psychotic symptoms. We make sure that they can understand the proceedings and cooperate with their attorney, and then we spit them right back out into the exact same circumstances that precipitated the arrest, or they go to prison, and then they're discharged a few years later with a felony on their record, making them even more disenfranchised from society. So what can we do about it? Well, that is why we are here today, and I am so glad that all of you have joined us. Next slide, please. Oh, when you're not controlling your own slides, you're not sure what the punchline is. So what I want to do is I want to ground us in some human beings. And these are actual cases that we pulled from 3 different counties, and it's just a case representation of the hypothesis I just gave you. One case was a 35-year-old male transient. The police were called because he was on a roof pulling the roofing tiles off the residence and throwing them off the roof onto the ground. He had taken off all of his clothing. One of the roofing tiles that he threw landed a foot from the officers when the police were called. He broke the skylight on the house. He doused himself with water. The police caught up to him. They tased him. He had no response. He ran away, and when he was apprehended, he was agitated, talking to himself, and struggled. And so he was charged with felony aggravated assault on a police officer and assault with a deadly weapon, which was the roofing tile, as well as felony vandalism. Next slide, please. Another case that illustrates our hypothesis. This is a 45-year-old transient male who went into a sandwich shop. He believed he owned it, so he felt the back door was busted, so he locked it, put crates in front of it, and asked the attendant of the sandwich shop for a Sharpie. He put an out-of-order sign on the door. Then he went into the bathroom, he cleaned the bathroom, and he expressed concern about someone slipping on the floor due to the excess water from him cleaning the bathroom. He then asked the clerk for some money in the register, stating, "Don't worry, I'm the owner." He was denied without incident. Then he asked for a sandwich, and the clerk was frightened, ran out into the next storefront, and called the police. When the police got there, the patient was clearly delusional about owning stores, and he was talking about Tony the Tiger. He was charged with felony false imprisonment and attempted robbery. Next slide, please. Final case to illustrate our hypothesis, very sad case. This is a 37-year-old transient male. Police were called when he refused to leave a fast food restaurant. He was asked to step outside, and he complied. And during the search, the police informed him he was not welcome. They put his hands on him, and he became upset and tried to get out of the grasp of the officer. It became clear that he did not understand that they were police officers when he tried to call the police on an imaginary phone. He was talking to himself about the devil. He was missing his left eye, and he informed the police that he took out his eye because the devil told him to. The police then attempted to handcuff him, and he struggled, thinking they were the devil. He was tasered multiple times, and he was charged with battery with injury on a police officer and resisting an executive officer, both felonies. So when you hear about felony people on our wait list, these are the people we're talking about. These are people who are homeless, symptomatic, and getting arrested as a result of those 2 factors. So from a clinical perspective, the IST commitment is a travesty. We're not doing anything to interrupt the trajectory of this person's course. We're just one stop, probably the on-ramp in many cases, to the criminal justice system. So then we ask the question, well, does it serve any kind of public safety function, this IST commitment? And the answer to that is no. When you look at our 3-year post-discharge recidivism rate, these individuals are going right back out into the community and getting arrested. Again, these are arrest recidivism data. And as you can see, year over year, it's about 70% of these individuals are just getting arrested again. Slide, please. again, does this serve any kind of public safety function? Well, many of these people are just having their charges dropped after they sit in jail for months waiting to come into a state hospital. We get them stabilized on medication, we get them ready to stand trial, they go back and their charges are dropped, and they go right back out into conditions of homelessness and being untreated. So in 3 years, we looked at discharges. 15% of those had just one offense, and of those, 35% had their charges dropped. That's a lot. That's 1 in 3 had their charges dropped. 85% of the people that we'd admitted had multiple offenses, and the charges dropped for that group was 24%. So we're not doing anything to interrupt the illness. We're not doing anything in terms of long-term mental health treatment. We're not doing anything in terms of public safety. These people are getting arrested again, and in many cases, they're not even standing trial. This whole concept of restoring them to competency to stand trial, and they just have their charges dropped. So this is madness. Next slide, please. Only 24% of the individuals who were sent to us over 3 years ended up in any kind of state institution. 24% were sentenced to prison, and then a very, very small fraction were committed to us as not guilty by reason of insanity. Slide, please. That means 75% are right back out into the community. And this is, you know, we talk about the waiting list in the state hospitals. That is one small part of this cycle of criminalization. These folks, if you look at it from their perspective, they're homeless, untreated, getting arrested, going to jail, coming to us, going back to the community, going back out to being homeless, untreated, getting arrested, going back to jail. We need to break this cycle. Yes, DSH is the only place in this cycle where they have a constitutional right to treatment, which is why they're all on a waiting list, waiting to come into us. But the hospitalization that we provide under this statute does nothing to interrupt this cycle. Next slide, please. Hence, our diversion program. So our diversion program is absolutely based on everything that I've just said. In our diversion program, we are looking for individuals who've been diagnosed with a schizophrenia spectrum disorder. And when we originally wrote it, we were saying it has to be schizophrenia, schizoaffective disorder, or bipolar disorder. Now, for you all, and any funding that we give out in the future, we have changed this because what this was doing is it was excluding people. It was too rigid. It was excluding people who had, for example, a diagnosis of unspecified schizophrenia spectrum disorder, and it was not a great way to slice the population. And then we said, oh, never mind, forget I just said that. Ashley has corrected me. We're still sticking to these diagnoses. But foreshadowing, perhaps we're going to try to loosen that up. These are people who have the potential to be found incompetent to stand trial or who have been found incompetent to stand trial. And there's a significant relationship between the serious mental disorder and the charged offense, or between the individual's conditions of homelessness and the charged offense. So I hope you can see these criteria that we've developed are to target the people in the cases I showed you and to target the people in the research that I showed you. We're trying to capture people who were arrested because they were untreated and unsheltered and get them into meaningful care in the community rather than have them go on that cycle that I just showed you. And these are people who would not pose an unreasonable danger to public safety, and people who commit crimes when they're psychotic without a lot of associated other violence risk factors. Once they're no longer psychotic, their risk plummets, and that's kind of the population we're trying to capture here. Next slide, please. I got logged out of my computer because I'm not advancing my own slides. Okay, so last year during the pandemic, we had the UC Davis Forensics Fellows look at 191 people on our wait list to try to see how many people on our wait list would qualify based on those criteria I just showed you for diversion. And they came back and they said potentially 47% of the people on the wait list potentially meet that criteria. That diagnosis, there's a nexus between their symptoms and homelessness and their crime. And if they're treated and they're stable, they can be safe in the community. Next slide, please. So this is what could happen with diversion. We have 1,700 people on our wait list. If 47% are eligible for diversion, that's 799 potential diversion candidates, and we're funding 820 diversion slots. If this worked, we could cut our wait list by more than half. Next slide, please. But what is happening with diversion, and this is initial data, so it's not totally exact, but of the 424 people that were diverted when we pulled this data, only 11% were actually on our wait list. And so we've been working with our diversion partners and doing case conferences and trying to figure out what the barriers are. And so Ashley sent out a survey to our diversion partners a couple of weeks ago, and the number one reason folks gave for not diverting people off the wait list is a lack of psychiatric stability. Next slide, please. And these are her results. So again, this is not science. This is opinion surveys that were sent out to our diversion programs. But these are some of the things that you need to be thinking about in terms of how are you going to get folks off the wait list, folks like the 3 human beings I just described to you. And the number one issues to some extent are related to getting people stabilized on medication. I just want to point out that DSH diversion dollars can be used to stabilize folks and pay for medication while they're in jail waiting to divert. Next slide, please. Okay, so that's the end of my presentation. Ashley can correct anything I said that was erroneous, and I'm happy to take any questions for the next 15 minutes?
Thank you, Dr. Warburton. It was just the diagnosis piece. We are still in
trying to work towards.
Yes.
We're trying to work towards opening that up.
Yes. Just haven't quite gotten there yet. So yeah, we do have 15 minutes for questions, and we have a couple questions and comments that came in during the course of the presentation. So I'll go ahead and read those, and in the meantime, if anybody else has questions that they would like to enter into the chat, you can go ahead and do that, or you can raise your hand and we can call on you if you have a question that you want to ask us directly. All right, so, and I just got a message that one of our questions was answered during the course of the presentation, so that's great. So this is kind of more of a, I think a comment, but I think it would be something worth speaking to. This individual wrote in that they love this presentation and have heard it a few times, but the hypothesis is troubling. It does not mention the utter crisis around affordable housing. When there is sufficient affordable housing, the behavioral health system can treat people in the community, but treating people who have no housing rarely works. It seems like a key missing piece of the analysis.
Oh, I don't think it's missing. I mean, I think the fact that half of the people coming into us, more than half, are coming into us unsheltered, and and that many of the crimes that are being committed is, things like trespassing, where they're getting arrested in part because of their homelessness status. It's a huge factor. And in fact, when we designed the program, what we originally did the math on was how much would you need to house someone and give them a case manager if all their mental health services were Medi-Cal reimbursable. And that's how we actually calculated our first number that we came up with for the grant money. So I think totally, absolutely 100% agree that housing is a fundamental part of this. And maybe I'll update my deck to make that more clear, since you've heard it a few times and I haven't made that clear. But we think it's an extraordinarily important part of this picture, and hope that you use some of our diversion dollars to provide that housing.
All right, Matt Garber, I see your hand is raised and I have unmuted you.
Hey, Ashley and Dr. Warburton, good to see you both. Just, whoops, one sec, can you hear me?
Yes.
Oh, there we go. Okay. Yeah, Dr. Warburton, just thinking as you were mentioning that last piece that a lot of the folks aren't being taken off the wait list because of inadequate psychiatric treatment in the jails, just reminded me of when I came from DSH to the counties and I called Ken Carabello with Liberty that provides psychiatric services in jails, and he mentioned to me that it's all over the place as far as there's not really any standard. Any thoughts of what psychiatric services are required to be provided in jails as opposed to the state hospitals? Any thoughts about how that might be something that might be needed in the state as far as setting standards for psychiatric care in order to alleviate this problem within the jails?
Oh, Matt, it's such a great question. I see you're still quite with it, even though you've left DSH. It is the question. You know, it is the question in my mind. It is since the pandemic, we've been going in remotely, and we've been evaluating all the people on our wait list and trying to figure out who's there and what can we do for them. And so much of it is just about psychotropic medication. So much of it is just about treating the psychosis so that the individual can function and make decisions. And, you know, and many people are sitting on our wait list who have involuntary medication orders, but they're not getting involuntary medication. I don't know. I always put my foot in it in stakeholder meetings, but I feel like if we could get everybody on our wait list stabilized on medications today, if we just started doing that today, we could divert half of them in 90 days' time. It's the missing link, in my opinion. And we actually have this big stakeholder group that we're doing, that the legislature ordered, and one of the whole work groups is around how to get people earlier access to treatment while they're waiting to come into state hospitals or go out to diversion. And it's complicated. You know, jails don't know how to involuntarily medicate a psychiatric patient because they're a jail, not a mental health facility, and this is a new paradigm for them. There's a lot of mythology and misconceptions around psychiatric medication. Very rarely is any kind of use of force or anything like that, or shots or anything needed with involuntary medication. Usually it's just a conversation with the patient where you say, hey, you've got an IMO, you need to take your meds, and the patient usually says, okay. And we actually have partners in San Luis Obispo County that we've been working with who started doing this, and they can speak to it much more intimately than I can, but it's working, and it's making things better in the jail because all the patients who are unstable in their jail environment are stabilizing, and some of those behavioral issues are going away. So it's a great question. I think the inability to get someone who has an involuntary medication order actually connected to their medication is multifactorial, and it has to do with just not enough information or understanding about the nature of psychiatric illnesses, I guess, is how I would answer that.
All right.
Thanks very much. And
nice to hear from you.
Yes, and I went to a book signing last night, and I was thinking I need to get a signed copy to Kate Warburton. So.
Yes, you do. You know where I am.
Yeah.
All right. We have a couple questions that have come in through the chat. So one question, I recall some research presented at the Forensic Mental Health Association of California citing a poor direct connection between mental health and criminal activity. There was a strong correlation between mental health and social determinants that led to criminal activity. Is this second order connection sufficient for the requirement of a nexus between mental health and criminal charges?
Oh, that's a really good question. And whoever you are, if you have the slides or the data that you saw, I'd just love to see it. I guess I would want to know a little bit more of what you mean, but what we're really looking for are people like the people in our vignettes who are so floridly psychotic that they are not oriented to the reality that the rest of us are experiencing, and who, because they are acting in a way that makes people uncomfortable and are also unsheltered, so they're acting that way on the street, have a situation happen where the police are called and they get charged with a felony. So, you know, all kinds of things drive criminal behavior. I've looked at cases on our wait list where someone, you know, broke into a car and stole a laptop because they wanted to sell the laptop, and that's not a nexus in terms of what we're looking for. But if the person broke into a car and started ranting to the police about how it's their car and they're trying to escape from the mafia, that's more of what we're talking about, where there's a clear connection between the symptoms and the act, if that makes any sense. You know, we're just trying to capture the people who have gone into a downward drift and who are being reinstitutionalized when they would be much more appropriate in care.
And I think Hallie also wanted to speak to this question. Hallie, are you off mute?
Apparently not. I started talking and no one responded. Am I off mute now?
Yes, you're off mute now.
Okay, cool. Thank you. I was chatting with Ashley. This is very much Dr. Demaray's expertise, but I can anticipate that the presentation may have been based on work done by Dr. Jennifer Scheme, who's looked at, and others who have done research looking at probationers and parolees to see whether the incidents precipitating their arrest or criminal justice involvement was, quote unquote, directly related to their mental illness. And so of all of those people, a small percentage of those people have that direct relationship, sort of like what Dr. Warburton was talking about. There was an hallucination that immediately preceded the criminal activity, and that research is often used to help explain why medication on its own medication may be necessary but not sufficient in terms of addressing the needs that bring people into contact with the criminal justice system. But there are certainly, as Dr. Warburton was saying, you know, a close connection for many people, either immediately before an incident they're involved because they're hallucinating or as a direct result of their mental illness. And then there's also, you know, and I think this comes up a lot as we talk about what brings people into contact with the criminal justice system. And I think Dr. Warburton had some examples of this, where a mental illness may lead to homelessness, which may lead to increased visibility to law enforcement. So someone in that situation wouldn't have showed up in Dr. Scheme's research, but I think as people are talking to each other, you would say that the mental illness was related to the criminal activity or to the criminal justice involvement. So yes, I can definitely put some of those citations in the chat, or we can send those out afterwards if that's helpful.
It is, and I've read her stuff, and I think it's tangentially related, but I don't think it's on the nose with our ISP population. I think our ISP population is a different kettle of fish. And, you know, I read, I don't know how many police reports every week, and this is much more about uncontrolled psychosis than it's about criminogenic risk, in my opinion. I mean, I think what she's done is a great amount of work, but it's on a slightly different group of folks. And we're really trying to capture the folks, like the people in those vignettes.
Excellent. All right. Are there any other questions out in the audience? Any other questions to go into the chat, or if you'd like to raise your hand, I can unmute you so you can ask your questions directly to us. And I will give it, how about we give it about 30 seconds to see if anybody else has anything to ask, and if not, we can go to the break a little bit early. Just keep scrolling. Okay. So I think with that, oops, got a question. Housing and medication are definitely key, but what about those who refuse? Will conservatorship need to happen?
Okay, so that's the great question. And if you look on that slide where we had the responses from the counties on the barriers to diversion, let's look here. I don't know if it's big enough for everybody to see, but the second bar down under the lack of psychiatric stability is about involuntary medication. And I know when we wrote this, we had a lot of lawyers and judicial counsel, other people involved, and we were trying to write it in such a way that this person could be ordered into diversion with all the terms and conditions. But I think counties are interpreting that in a variety of different ways. So that's something, if your county wants to contact us for some TA or, I think keeping people on their meds is sort of a non-negotiable element of this program. And so I know that different counties have addressed it in different ways, I'll say it that way. And that's one of the things I think we're talking about in that large statewide stakeholder work group.
Right. Thank you, Dr. Warburton. Any other questions? Do another 30-second pause to let anybody who may be typing away furiously finish their question or thought before we go to our break. All right, so I think we may be done with the questions at this point. Thank you so much, Dr. Warburton, for your presentation. We really appreciate you being here with us today. And with that, we're going to go to our last break. We have a 10-minute break. Quick note, if you can please check the chat box. If I put your name in the chat box, asking for your county association, and I think I got everybody, but I think I might be missing one person, so if you can please check and make sure you let me know which county you belong to so I can get you assigned to the appropriate breakout session for when we come back from break. I would really appreciate it if you could all be back in 10 minutes at 3:40 so we can move into the final part of our day. That would be awesome. We will see you all back here soon. Thank you. All right, everybody. It is 3:40, so we are going to move into the last part of our session today, which will be your county breakout session. So I am going to turn things over to our partners at the Council of State Governments Justice Center to take over. Oops, I think you're on mute, Katie.
Okay, can you hear me now?
Yes.
Okay, thank you. So I'm Katie again. I am a senior policy analyst at the Council of State Governments Justice Center. You know, Hallie provided some background about our agency, but we are a national nonprofit, nonpartisan organization. We work with all three branches of state government, and we do policy, research, analysis to develop strategies to increase public safety and strengthen communities and community engagement. Next slide, please. So as we mentioned at the beginning, each of you have a CSG staff as your facilitator throughout this whole series of the Academy to help you work on your program plan, just to be a resource for you as you're working through this process. So here are the assignments. There might be a couple, like Rosemary, I think, will be working with Nevada along with Sheila. But these are your assignments. So in just a couple minutes, you will be meeting with your facilitator. Next slide, please. Okay, so we're just going to go through some of the questions that you're going to talk through during your breakout group. But before we do that, just a couple kind of logistical things. One, we'd really appreciate if everyone turned on their camera during your breakout group. Just much easier to have a group discussion when we can all see each other. So please do that in your breakout group. You know, obviously just start with introductions of your team so that we can get to know you again. And, you know, we're not sure how well all of you know each other in your team. So please start with that, and then we'll go through the questions. And then in your breakout group, you know, one person should be assigned as a note taker because, again, all the questions are going to relate to your program plan that you'll need to submit to DSH that Ashley talked about. So just make sure someone is, at least one person, is taking notes. And then after our breakout group, they're going to come back together as a larger group and report in. So please make sure someone, it can be the note taker or someone else on your team, is going to be reporting in on like the main things that you talk about in your breakout. And so in terms of the questions, and your facilitators will have these questions, so don't worry about like, writing them down. But first is, what are your overall visions and goals for your diversion program? Why is it important for your county to start diversion now? I think Dr. Warburton did an amazing job explaining why this is important now, but we really want, you know, specifically for you, why is this important? Next slide. Yep. You're also going to identify your county stakeholders and their role and responsibilities in your diversion program. So, you know, that would be all of you that are here now, but there might be other people that aren't here that you're going to include. What are the activities that will be undertaken by your collaborative partners to support diversion implementation? What is your proposed program staffing? Include all stakeholder groups. Next slide, please. And again, I mean, all of these, like, just answer to your best ability right now. You don't have to have, like, an extremely thorough plan right this second. That's what we're working on. But if you can provide a brief description of the services that will be performed by the different positions. And again, this can be a little more of a brainstorm if you haven't gotten all the way there yet. So for example, are you envisioning like an ACT treatment model, incorporating peer support, full service partnership? What will the classifications of different staff be that will be used for diversion? Will your diversion program plan to employ peers or staff with lived experience at all? What's your program's recruitment strategy? You know, we know workforce development is a challenge, so we'll definitely talk about that. Next slide. What is the time base for each position? Will any existing personnel be redirected towards diversion? And then identify any program services that might be subcontracted. So that's a lot, but we have about 40 or 45 minutes, I believe, for these breakout groups. Hopefully we can get to most of those things. But I think Ashley is going to talk through some technical full logistics for the breakout group next, right?
Yes. Yes. So I just wanted to let you all know kind of what will happen. I am going to have to stop sharing the screen so I can open up the breakout rooms, and I'm going to need just maybe 90 seconds of additional time. I have a few late registries who I need to get assigned to their breakout room, and then I will start the session. Once I start that session, excuse me, you will see these two pop-up boxes, one after the other. One asking if you want to join the breakout session. Please click yes. And one asking if your audio, if you want to continue with your audio being switched over to the breakout session, please click yes, or else you will not be able to speak. And you probably won't be able to hear. Once you are in your breakout session, your facilitators from CSG are the presenters, and they have the ability as presenter to mute and unmute you. Theoretically, you should all go into the breakout session unmuted. But if for whatever reason some of you are muted when you enter in, CSG folks, just a heads up to you, you can click on a person's name and click unmute, and that should do it for you all. So why don't I go ahead, and I'm going to actually start by just unmuting folks in this main session, because I think that might help us get folks into the breakout session without being muted. So give me one moment to unmute people in our attendee list, and do that very quickly. Run down all of this.
Hello?
Hello, I am in.
No work.
All right.
Well, I've been trying to tell
I mean, while Ashley's doing that, are there any questions about what we're going to be doing in the breakout groups that people want to ask? Are they large?
All right, everybody. I don't know that I see any questions in the chat, so I'm going to open up the breakout session now. Again, I think we have a few people who are still here with us. If you can please make sure to click yes to entering the breakout session on your computer, as well as the audio conference. That should push you over into your group.
Oh.
All right, so we wanted to just take a little bit of time at the very end, and we'll probably, time permitting, do this every session, just to have you all kind of report out a little bit on how things went in your breakout sessions. If we could, as I mentioned, maybe keep it to the work that was done, and if there were technical issues, if you could just please put that in the chat, that would be helpful. So I think I'll turn it over to Hallie first. I believe you had Madera County, Hallie, and see if you guys have anything to report out.
Can you hear me all right?
Yes, I can hear you.
Okay, cool. I lost my panel somewhere. But actually, Julie from Behavioral Health for Madera was going to do the report, and that's Julie Morgan.
Okay, let me unmute you. Give me 1 second, Julie. All right, Julie, you should be unmuted.
Thank you. I think it went really well. So it really was the beginning of this process. So it was really helpful to kind of work through some of it and some feedback from Hallie on what other counties are doing. So we had a vision and our kind of goal as to what we want to do, which is divert and reduce the percentage of in-custody population that we have and provide comprehensive and collaborative community-based treatment for that population. So being able to hear some feedback about potential things to be on the lookout for, what other counties have encountered, really other community partners to think about, including, was really helpful.
Excellent. Thank you, Julie. How about Nevada County? Who do we have who can speak for Nevada County? If the facilitator could let me know, I can go down and unmute an individual if there's somebody specific who was identified, or I can just turn it over to our CSG facilitator. Let me know.
Yeah, hi, Ashley, this is Sheila. I'm going to turn it over to Phoebe Bell, if that's okay to do, Phoebe, to do the report out for Nevada.
Let me open. It looks like Phoebe is unmuted.
Hi, yeah, so I think on the positive side in our group, I think we have good representation of all the key players and shared agreement that when possible, community-based treatment is going to be much more beneficial and what we all want for people who are suffering in jail with serious mental illness. I think we have a lot of questions of kind of core concepts around how a DSH diversion program should work, including sort of how do you define exactly somebody that's likely to become IST, sort of what's the judicial pathway for folks who already are IST, how do they get diverted in this way? A lot of questions around the medication piece and how that works in a small county without a ton of, either in jail or in community psychiatric treatment, but like involuntary med options. And then some questions around sort of the financial model that when you're looking at sort of one or two people potentially, how do you kind of build a supportive program with that kind of funding model? So those are some of the things we're struggling with, and I think hoping to get a little more like engagement on sort of those technical pieces to help us figure out how we see something working in Nevada County, but interested in engaging in more dialogue around that.
Great. Thank you so much, Phoebe. All right. What about San Joaquin County?
Hey, Ashley. I believe, was it going to be Judy Ann that was going to talk about the plans moving forward?
Hi.
Yeah, so we talked a lot today. I think,
each of our individual stakeholders who is here at the meeting today, we've all kind of been working on our own individual pieces over the last few weeks, and so we're planning to meet on Monday and kind of just regroup and figure out where we're all at. I think some of the biggest issues that we identify that we could use help in is really getting the buy-in from the judges, from the local community and the organizations for a diversion program. I think there's a lot of pushback here in the community, and Joy was going to give us some ideas on how to get that going, as well as the housing. That's something that's been a problem for us for a while now. We've got a very high homeless population, and I think any program is going to fail if we don't have a solution for the housing problem.
Okay, thank you, Judy Ann. Let me see, Stanislaus.
Great. We're going to have Chandra Campbell talk about Stanislaus, please. Ashley.
All right. Chandra, you are unmuted.
Great, thank you. Very similar to the counties that have already spoken, I think the representatives that were here today truly are invested in it, and we're excited to get it moving forward, but there is still a lot of work that needs to be done just in regards to educating the community at large about the need for diversion. We also have a lot of questions just about, some of the processes and kind of how to move that forward. And then similar to San Joaquin County, one of our biggest issues is housing, and then we also talked about hiring and recruitment and some of the struggles that we're experiencing with that. So looking forward to further discussions on those.
Great, thank you, Chandra. All right, Tulare County.
Well, I am clearly not an expert in the county, so I might ask if Dr. Alyssa Huff can report out on this.
All right, give me one moment. Dr. Huff, you should be unmuted.
Hi, good afternoon. So we definitely are excited to hear what other counties are doing. We've been doing a pilot diversion program for a while, but we're working on growing that and making some changes. And so having a more formal process of getting together our stakeholders and discussing how to move forward. And we've added some stakeholders than we had before. I think we're really looking forward to that. I'm going to echo what everyone else has to say about housing. That is a huge issue. And I think our public defender really hit it on the nail too. It's not only that we don't have enough housing, but then these consumers are ones that have burned bridges at all the housing we do have. And so we really need new housing for them to go into, because the existing housing knows their names and won't accept them. So looking at that, I'm also excited about the prospect of having peer support specialists. And so that was something we discussed today because we do use it throughout our county mental health system, but considering it specifically for this program, because we've been doing a pilot, we have some individuals who have completed mental health diversion now. So that's exciting as a potential to use them in that way. And we also talked about we're struggling with individuals who are very, very ill, and how can we get them into community diversion? Our hospital within our county is not owned by the county. It's we contract with the psych hospital, so we have a very difficult time. We can't get them, hospitalized while they're in custody. We try throughout the whole state. We can't get anybody to take them when they're in need of psychiatric hospitalization. So, that makes us look at, okay, well, the contract provider that's providing the mental health services in the jail. We heard Dr. Warburton talking about that today, and that other counties are expressing difficulties with involuntary medication and things within the jail. So then, how do we stabilize individuals? are we going to see too many people that are too sick to come into community diversion? So looking at those aspects and how, is there something we can use the funding for in that aspect? So these are some of the things we discussed today, and I think it's really helpful not only to get our own county stakeholders involved, but then to hear what other counties are discussing and talking about.
Excellent. Thank you, Dr. Huff. And then how about Tuolumne? Oops, and I think I have somebody I need to, give me 1 second. I realize that I have a technical issue here. Let me find Jennifer. I'm sorry, Jennifer. Oops, I don't know that Jennifer is still here. Do I see her? Ah, there she is. Sorry. Sorry about that, Jennifer.
It's okay. There always has to be one special person in a training, and I'm not a special person today. Yeah. So for Tuolumne, we have Betty Hoskins, who is going to give a report out. So I will turn it over to Betty.
All right, Betty, you are off mute.
All right, can you hear me?
Yes.
All right, we did have some difficulties around echoing and the audio for us. But we talked a lot really identifying some barriers. So again, housing, the timeline for doctors to actually come and do the reports, and the time that the clients themselves are remaining in custody. Staffing is a big issue. We looked at trying to, again, look at how our agency partners, we can get together and brainstorm about how this process would work for us. We do tend to have a smaller number because we're a smaller county. However, even knowing that we have 5 or 6 on the wait list for Napa right now is still too many sitting in the jail waiting for that type of placement. We looked at which individuals would could participate in this, making sure that we had a really good risk assessment, looking at the defendants and beneficiaries, looking at using different funding sources for our match, and a lot of discussion around who decides regarding the eligibility and assessment. Holly Gorman brought up a lot of good information on the 215 with the mental health professional being able to come in and initially do something once the public defender or attorney notices that there's something off, maybe even prior to having the doctor's referral be sent. So I'm looking forward to it. I think it's going to be really exciting if our county does opt into this. So that's what I have. I'm not sure if Michael has anything else he wanted to add.
Let me see if I can unmute. You said, is that Michael Wilson?
Yes.
Just 1 second. All right, Mr. Wilson, you're unmuted.
I don't know that I have too much to add. It was a good conversation. Good to bump up against the mental health diversion, grabbing these individuals before they are incompetent potentially, but not ignoring that aspect if they are. So we have a lot of work to do here. I mean, it's a manner of bringing everyone together, and we've got a great team.
Okay, thank you.
Not much else to say.
All right. Well, thank you so much, everybody. And I've got a little bit of I'm gonna, there we go. I think that takes care of it. So thank you all so much again for joining us today. We're going to get you out of here about 5 minutes early. It's a long session. We appreciate it. Our next session is October 13th, where we will be focusing on how you identify and assess appropriate diversion clients, talking a little bit about defining our target population, screening and evaluation tools, risk assessment, stakeholder roles and responsibilities in this area, and we will be featuring both Dr. Deb Heinels and Dr. Sarah Demaray during that session. So we look forward to seeing you all there. Thank you for being with us today. I hope you all have a great rest of your week, and we will see you in about 2 weeks. Thank you so much.